All right, y'all, folks on YouTube, this is a little bit weird because we've been hanging out with a local crowd here for about 10 minutes or so, getting to know each other in the breakout room. I will repeat myself in saying that this is the first time we're doing a shift in the ER together. And I will tell you a real life story as it unfolded with a little bit of a dramatic flavor, just for storytelling purposes. But I remember there was a time in the emergency room when I was just getting situated with the place that I work. It was a few months in, and it was very busy, very, very busy. I walked into the shift, and my colleagues, I was one of the one or two people who were coming on into a very busy volume. And I remember seeing 3 patients who hadn't been triaged yet, who were showing up on the screen of new patients, all with all is white, that they haven't had any triage. And then within 2 minutes, their chief concerns pop up. And I will tell you 3 patients with these 3 chief concerns. Crazy. The first was a patient who showed up with shortness of breath. The second was a patient who showed up with chest pain. And the third was a patient with hypoxemia. All right here. And our newest team member, Aisha, is scribing today. I'll tell you which one we're going to talk about in more detail, Aisha, so hang tight. The first task that I will actually give you is to go back in your breakout rooms, because you have a tough decision to make. You're just walking in now, and you have 3 of these patients to see. Who will you see first? Who will you see second? And who will you see third? And remember, you do not have the luxury of any more data. You don't know anything about anyone. This is all you get, and you have to make a decision. So who do you see first? Who do you see second? Who do you see third, and why? Back to the breakout rooms we go, and I'll tell you which patient we ended up seeing first in a sec.
Rabih, I have a question.
Yeah.
Is anyone sharing the screen?
Well, I think it typically is you.
I think it's the person doing the teaching points.
Do you know who that? I think it's Alex. I think it's probably, since you're going to be doing the most typing, I would just go ahead and do it. I
Okay,
just gave you the co-host privilege, so you can do it.
Thing is, I don't know how to record it and then upload it.
Oh,
So
I'm
if
recording it.
just for today. Oh, okay.
Yeah,
Oh, okay. So I can share.
yeah. All you have to do is, don't worry about anything else. All you have to do is just share screen. That's it. And then we'll
Okay.
take care of everything else afterwards.
Okay.
Cool.
So if I share my screen while I'm on the Google document, would I still be able to see the chat?
Yes.
Oh, okay.
Yeah.
Okay.
Yeah, it should
Sorry.
be okay.
Little...
But also, by the way, when you're scribing, I would try not to. You're trying to like not get so much stimulus. So I would try. When I used to do it, I wouldn't look at the chat. It was just too overwhelming.
Oh,
But you should
really?
do you.
Oh,
Yeah.
okay.
Just like stay. The way I'll present to you, it'll be very little information. It'll be very little to write. It won't be hard. And if you have any clarifying questions, you don't have to go to the chat. Just ask me. Just unmute and ask me, just like you did now.
Okay, perfect.
Cool.
Thank you.
Okay. Awesome.
Thank you.
All right. You should totally hop into the breakout room and just learn from people, you know? Okay. All right. So for folks on YouTube, I just wanted to, for those of you who are watching on YouTube, just want to emphasize just how much more dynamic and alive the experience is here when you join us live. I really, really encourage it. Although, of course, I understand that asynchronous learning and joining on your own time is, of course, incredibly valuable. I can only join a certain fraction of VMRs myself. But in case you didn't know how to join us live, I'll share with you that all you really have to do is go to the main Clinical Problem Solvers website. So that is clinicalproblemsolving.com. Hopefully you guys see that screen. Let me see, make sure you see it. Wow, I'm not very Zoom savvy. Yep. So you go right here, and then you go listen, watch, and then you click listen, watch, and you click on VMR. And basically it has everything that you need here to be able to join us live. And the main advantages are that you become part of many people who are like you. There's so many people who watch the VMRs live. There's so many people who watch the VMRs on YouTube just like you are, but so many of those people come and hang out and connect and join each other. And in real life on Zoom, which is really, really cool. It, of course, is a great way to build community and to talk about medicine, but many of these people get to know each other outside of medicine and help each other navigate the challenges of medicine, especially folks who are international medical graduates. There's a big, big IMG community within CP Solvers who join live, and it really helps build bridges, get to know ideas, and helps in many, many ways. Joining us live is also, if you're ever interested in becoming a CP Solvers team member, the pathway to that is to join us live, and you can learn more about that on this webpage. So hang tight, think through that question of which patient are you going to see first, and think of your rationale why. Why would you see blank first, blank second, and blank third? And if you're on the fence about joining, I highly, highly recommend it. Check out clinicalproblemsolving.com, go to Learn Live, and hopefully you'll have a good time with us. But for now, hang out, and you can actually forward the video to when we come back. Hang tight, and we'll see you all in a second. Hello,
Hi,
my
Rabih.
friend. How are you?
I'm fine. I was scared because I went to another breakout room and I just text you saying like, "Hey, is this a new format?"
Yeah, we're doing a lot more breakout rooms.
Got it.
Yeah, I think that it's a little bit unfortunate because for folks who are watching this on YouTube, it's less like engaging and whatnot. Um, but I think that the ability to sit here and talk amongst people is just so cool. So we'll see how it
Yeah,
goes.
so powerful. Yeah.
Yeah, I completely agree. And hopefully, it'll for people on the fence, it'll push them to think about joining in real time. Where are you now?
Baltimore,
In
but what?
Baltimore, huh?
Yeah.
Have you had any vacation back to Peru recently?
Yeah, I went for 1 month.
A 1 month? Wow, that's amazing. That's so
Yeah.
cool. How does it feel to be in R2 now?
I'm scared, but I think I'm prepared.
I think it'll be absolutely amazing. Good to see you, Franco. All right, y'all, let's rock and roll. So maybe I'll just go in the team room. So Deborah, do you want to summarize what you guys settled on? What did your group settle on?
So we have a little bit of a controversy
Okay, good.
about the number one, if should be shortness of breath or hypoxemia.
Okay.
But we have like an ER doctor, so we have an advantage and
What's up, Travis?
so I think we should go first for the hypoxemia,
Yes.
then shortness of breath, and go for the chest pain and nothing. We remember the schema of chest pain that is really helpful
Yeah.
in a moment like this. I will
Yeah.
add to the chat.
Amazing. Yeah, we'll talk about that in about 20 minutes, hopefully. So your order was hypoxemia, shortness of breath, chest pain. Is that right?
Yes.
All right, let's come to one more group. Maybe Sheima's group. What did Sheima, was your order different from Deborah and the room one?
We had the same problem, like we couldn't decide between shortness of breath and hypoxemia. And then we came to the discussion, usually we don't have the chief complaint of hypoxemia generally, just rather shortness of breath. So then the majority was like, yes, we say shortness of breath, and then hypoxemia, and then no. We also couldn't decide whether hypoxemia and chest pain. So there was also one point of this discussion, and the breakout room ended.
Amazing. Well, I'm glad, I still remember that feeling where I was like, oh my gosh, left, do I go left? Do I go right? Where do I go? Like, where do I start? And I thought about this for 4 years until I can actually teach you and explain to you that there is a specific answer. And that answer is to first see the hypoxemic patient and then see the dyspneic patient and then see the shortness, then see the chest pain patient. You guys see the screen okay?
Yeah,
So,
Rabih, what do what about letting the ER staff tell you where to go? That's usually
oh
what I
yeah,
do.
but that would completely negate this educational exercise. I love it. I think, Travis, the point that you should really, really, really listen to what Travis is saying here is that you don't have to make this decision on your own in real life. There are a lot of incredible people who are there to give you guidance. And by the way, the real answer is whichever the nurse tells you to go see, you should probably go see. Like, that's the real answer. But what we're really trying to understand here is I think a lot of these complaints get confusing. What's my approach to shortness of breath? What's my approach to chest pain? What's my approach to hypoxemia? And they get confused, but they're actually very, 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 very different, although there's a lot of overlap. So we'll just spend 2 minutes starting to tease out what the differences are between these neighbors, recognizing that there's a lot of overlap. Chest pain is basically, this part hurts. And the vast majority of patients who come into the emergency room have a non-morbid cause of chest pain. Vast majority. It's GERD, it's costochondritis. Only less than 30% of patients across many studies in the United States have a life-threatening cause of chest pain. Probably less than that. What about dyspnea? Dyspnea means this is failing. It's not working right. It's not that it doesn't hurt. It's that it may or may not hurt, but it's not working to its optimal function. And of course, there are some non-acutely life-threatening causes of shortness of breath, like panic attack, for example. But you can see, just look at the chest pain schema on CP solvers and look at the dyspnea schema on CP solvers and count the number of benign diagnoses on chest pain, benign meaning non-life-threatening, and count the number of causes of shortness of breath that are not life-threatening. You'll see that chest pain has many, 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 many more benign causes. In large, stark contrast to dyspnea. Hypoxemia confirms a sinister cause, period. If your lungs require support from the world, they're not working right. And of course, there's many caveats in the emergency room that Travis pointed out. What if the hypoxemia is actually a person who's COPD who's on chronic oxygen, not new? What if the patient who has chest pain turns out to have an aortic dissection? What if the person who has shortness of breath turns out to have a massive pulmonary embolism? You don't know that, right? So you have to use all the data. But this will begin a journey for us in this recurrent series of these ER shifts of really teasing out these adjacent complaints. And hypoxemia is by far and away the most morbid, given no other data. And by the way, has the most localizing value, because if your patient has hypoxemia, they have a lung problem, period. They have a problem in their lungs. The caveat may be that the reason they have a problem in the lungs is because their heart isn't working, backing up fluid into their lungs, or their nerves aren't working, so they're aspirating, but they definitely have a lung problem. That's in stark contrast to dyspnea, where the problem may be psychiatric, or chest pain, where the problem may be in the chest wall. Okay. So today, because of how sick this patient is, we're going to go see one very, very ill patient with hypoxemia. And Aisha, you can go ahead and share the screen whenever you're ready. This is the case that we're going to talk about that left an imprint on me for a long, long, long time. So this is Mr. D. He's 65. And before you know much about him, you walk in to see him and you can see why the chief concern is hypoxemia. He's already, having just come to the ambulance on 1 liter of oxygen, he's already now on 6 liters of nasal cannula. And Aisha, the screen looks great. Thank you for sharing it. So he's 45. And all you know so far is he is dyspneic and hypoxemic, requiring 6 liters of nasal cannula. And instead of telling you the history, I will tell you what my eyes first noticed. This is a gentleman who's sitting up, who is in significant respiratory distress, using accessory muscles to breathe, panting, panting, panting. His respiratory rate is probably around 32. Let me give you the rest of the vitals before I tell you what I did next. He's afebrile. His heart rate is 120. His blood pressure is 210 over 110. His respiratory rate is 32. And he's satting 95% on 2 liters nasal cannula, 6 liters nasal cannula. I want you to picture this patient. Severe respiratory distress, tachycardic, hypertensive, tachypneic, and hypoxemic. There's no time for diagnosis right now. You have to do something. So I go back into breakout rooms and have you guys manage this patient. And by manage, I want you to just think about the first 5 minutes. What tests are you going to order? None of them are going to be back. What tests are you going to order? And what treatments are you going to initiate? But before we do that, I'm going to give you the exam just to make it real life. So this is maybe a 30-second exam. Neurologically, he looks fine. He's moving all his extremities. He's conversing, but very, very difficult to speak. It was very hard to appreciate his JVP because he was moving so much and his neck was moving so much. So I had no idea. I put a stethoscope on his chest. I didn't hear any murmurs, but he was very tachycardic. And just in his lungs, crackles everywhere, but breath sounds on both sides. And his belly is soft and non-tender, and he had no peripheral edema. So I'll summarize. Just because you're in the breakout rooms, you won't be able to see the screen. So I'll hit you with the highlights. Tachycardic, hypertensive, tachypneic, hypoxemic, everything. And the pertinent exam findings are he's very tachycardic and he has crackles in all lung fields. All right. See you all back in a few minutes, okay? All right, y'all. For those of you watching on YouTube, I really, really encourage you to sit with your thoughts and ask yourself exactly what you would do in this circumstance. So write it down, practice it, and we'll compare your notes to what the audience comes up with here in real time in a moment, okay? All right, see you all in probably 3 or 4 minutes. For those of you watching on YouTube, thank you for your patience. About another 30 seconds before people come back. But again, you got to join. Folks are having a blast in the breakout rooms. And yeah, if you can make it in real time, I think that would be really, really cool. What's up? How's it going, Austin?
It's going well, man. How are you?
I'm doing very, very well. Very well,
Thanks for
thanks.
doing this today. It's very
What's that?
cool. But thanks for doing this today. It's very cool.
Oh, of course. Kidding? Of course. All right. I think everybody's back. No, not yet. Almost. All right, Dream Team. I think most people are back. Yaz, what did your group settle on? What do you want to do? I think you're muted.
Oh, me, Jazz, or Dr. Jazz?
Oh, yeah, YAZ. Ha! I should say a full name.
We were thinking about
Yeah.
giving nitroglycerin for his hypertension.
Amazing.
Also, we're thinking about furosemide. We were actually engaging in a very interesting things because we have, for example, Queen that's from Nigeria, Noah in Brazil, as well as Mariana and Shema in Germany, of course, me from Mexico. We're thinking, well, why don't we give him Urapidil, said Shema, it's an alpha blocker. And we were like, that, you know,
What's that? Yeah.
alpha blocker. So that, and for labs, ask for CBC, ABG,
Mhm.
ask pro, I forgot the little letter, pro MPP, I forgot.
VNP. That's okay. You got it. Pro VNP. Yeah. Yeah. The chat is like bailing you out times 10.
In Spanish, and I'm like, wait.
That's okay.
But
Mhm.
basically that,
Mhm.
because we're also thinking this pulmonary edema,
Yeah.
and
Mhm.
as Dr. Travis mentioned before going to the breakout rooms, this might be an sympathetic escape, sympathetic crash and acute pulmonary edema.
Yeah.
Take care of.
Yeah, no, I think that's absolutely superb. Yusuf, what did your group chat about?
We were discussing how 6 liters and patients' inability to speak is making us think this could be hyperacute.
Yeah.
So we also discussed having our point of care ultrasound with us in the interim, like trying to look for crackles bilaterally or signs of fluid. In the meantime, we wanted to order a ABG chest X-ray trope and check the kidney function and the CBC and the chemistry. And at the same time, if there is signs of fluid, we could consider BiPAP, for example, and the consideration of escape and or flash pulmonary edema, and in the interim while we work that up as well.
Absolutely superb, my friend. Absolutely superb. The whole goal of actually taking our time and slowing down in this is to really arm you all with a schema about managing shortness of breath before you have diagnostic clarity. And this is the visual here. And I think you hit all the highlights. There's really, it's really important to give it your best attempt to try to distinguish if somebody's shortness of breath because of their oxygenation issue or a ventilation issue. An example of a ventilation issue would be somebody having COPD, for example, where your management is much more about helping air move in and out rather than giving oxygen to the alveolus. And as a sneak preview, 2 sessions from now, not this next session, the session after that, we're going to talk about this. So I'll direct your attention to the problem that you have right now, which is that your patient has hypoxemic respiratory failure. And you'll see that the parallels exist where you need to suction something, you need to give oxygen, eliminate carbon dioxide, or a pharmacological therapy. So it'll come in handy next time. So every time you're in the situation, think suction, and the thing that you'll have to think about is suction of the pleural space in case the patient has a tension pneumothorax. The tension pneumothorax is defined along hemodynamic parameters, not necessarily hypoxemia, but patients can collapse their lungs so much that they can get hypoxemic. So always think, do I need to suck pleural air out? And that's why the exam in these patients is so crucial, to reduce the possibility of a pneumothorax. But then again, imaging in the form of point-of-care ultrasound and a bedside x-ray will be adjuncts. But you have to think about that, whether or not you deploy it right away. You also in parallel have to think about pharmacological therapy, and almost everybody who's hypertensive should probably get empiric diuresis and blood pressure control. The downsides of these in a patient who's hypertensive is virtually none. Again, you can't assume that somebody is tachycardic and hypertensive and these are the causes of their hypoxemia, but the overwhelming probability is at a bare minimum, these things are not helping. A sick heart with so much blood pressure and the afterload it induces is almost certainly contributing at least and probably even causing all the symptoms that the patient is having. So what are some pro tips here? I think the couple of tips are to recognize that you really have many options in this situation. There is no go-to evidence-based therapy, and you'll see that the global patterns vary widely. In our institution, we lean heavily on the use of nitroglycerin in this circumstance for a variety of reasons. But our ER, it's very easy and quick to get nitro paste. Nitro paste is nitroglycerin in paste form. It is rapidly acting when applied on the chest and can be easily wiped off if you make a mistake by giving somebody too much. So it is so quickly reversible, and which is why we use it. Pharmacologically, it's also helpful because not only does it help with the systemic blood pressure, it is a venodilator. So it dilates the veins, increasing the capacity of the venous system to hold on to the fluid that you think is making it into the lungs. So it has dual purposes here. But I will tell you one thing with much more confidence than the right blood pressure medication to use, which is the amount of diuresis you should give this patient. In the world of management, there's a lot of controversy and a lot of opinions, but there's very few people who disagree on that you need to give this patient whopping doses of diuretics. This is not a patient to try 20 milligrams of IV Lasix or 30 milligrams of IV Lasix. Why? Loop diuretic dosing and efficacy is under the concept of a threshold effect, meaning that somebody will not urinate twice the amount in response to you doubling Lasix. What happens is that the pharmacokinetics of diuretics are such that you have to reach a certain threshold, a certain dose after which the patient urinates. So if you're thinking about it simplistically, assume our patient's diuretic threshold is 40 milligrams of Lasix. He won't respond at all if you give him 39 milligrams of Lasix, and he will pee like no other if you give him 41 milligrams of Lasix. Of course, that's a lab construct that isn't exactly true in real life, but it pushes you to be very deliberate about choosing high doses of diuretics. And I will tell you, in a patient like this, I will never, ever give anything less than 80 milligrams of IV Lasix. Because if I'm wrong, easy fix. Very easy. Some fluids and we're done. Highly recommend that you be very aggressive about diuresis in this patient. Okay, so what happened? Immediately in the next 2 minutes, 80 milligrams of IV Lasix was drawn up and given, and he was given 2 inches of nitro paste. And I swear to you, within 5 minutes, his blood pressure is now 170s. His heart rate is still tachycardic at 105. His tachypnea improved, and his hypoxemia stabilized. He wasn't skyrocketing. And all of a sudden, the temperature in that room slowly went down. And in the next 10-15 minutes, all the data that you asked for will come back, and I'll give it to you, but I'll tell you what happened. Remember those 2 other patients that we had, the chest pain and shortness of breath patient? Well, good news, other people came. They actually were being taken care of by other attendings in the ER. So naturally, I went to see the next patient, knowing that my patient who was hypoxemic was not getting too much better, but I had a few minutes to go out and keep the ER flow moving. And I walked into the triage room blind. The patient hadn't been fully triaged yet, so I didn't even know his chief concern, but let me tell you what I saw. And Aisha, just for you, since you're scribing, you don't have to write any of this down. It'll hopefully become clear soon. So I walk into the room and I see a man who appears to be in his 30s, 20s, 30s, definitely not more than 40s, and who's holding a bag full of, you know, the emesis bags, the bags to vomit in. He's holding it and it's half full, and he looks horrible. He looks really ill, just like somebody who just vomited. I look over to the right of me, to the left of him, and I see that he is tachycardic. His blood pressure is, his heart rate is 110. Thankfully, his pressure is okay. His blood pressure is 120. And so I'm like, oh, wow, he's really vomiting and he looks very, very ill. And so I just start talking to him, of course, after introducing myself. And he tells me that he was fine yesterday and woke up this morning, was fine. And then in the middle of the morning, he started to get acutely nauseous, really, really nauseous, and started vomiting over and over and over and over again. He vomited at least 4 times before he came to the emergency room. I haven't looked at his chart yet, but he's pretty, he says he doesn't take any medications, he's pretty healthy and has a very, I'll keep it HIPAA compliant, he has a very stable job. He has no pertinent health-related behaviors, and I told you his vital signs. And I'll tell you his exam and then summarize. His exam, apart from what I tell you, he doesn't look great. I palpate all 4 quadrants in his belly, and all of them are soft, and they all do not concern me. So I take a second and I kind of like formulate my problem. This is exactly, and when I mentally do that for like 3 seconds, kind of slow down and see, okay, I have a 30-ish, otherwise healthy man who is coming in for hyperacute nausea and vomiting without much pain and with a normal reassuring exam. He's not peritoneal or anything like that. That was my mental summary of him. And so I asked the nurse to please take him to a bed, get an IV in, hydrate him, get some basic blood work, and we'll see where he settles. We just made a big mistake. And I will tell you that mistake, and hopefully a mistake that you never make the next time we do this. And because it is a very personal story, we won't be recording that session. So I'm telling you now to think about joining and discussing in real time a very, very eye-opening case of abdominal pain, nausea, and vomiting, where in what I just told you now, a major mistake was made. Any clarifying questions from the group about the data you have so far? I can't tell you, that's all you get, no more information. But anything that wasn't clear from the first 2 minutes of seeing this patient. He's in his 30s. Oh, I don't remember the last thing I said yet. I said so many things. Color of the vomit, a superb question. There was no blood in the vomit. I'll summarize for you one more time. Yeah, I don't remember the last thing I said, but I'll summarize one more time at the end, okay? Other questions?
Projectile.
Oh, I heard somebody's, I don't know if that was
Yeah,
it.
the whole projectile was it
Oh, great question. I'm sorry, I missed your name. What's your name?
only
Anyi, where are you calling from?
Nigeria.
Oh, awesome. Awesome. Welcome. It's so nice to have you here. His vomiting was not projectile. No. Great question. Really, really good question. Other questions, y'all? Sorry, Yusuf, we don't have the EKG yet. Just to be clear, this is a monitor with just a heart rate on it. So there's not even a tele lead. He's just in the triage room with a pulse ox and a blood pressure. Was his partner at the bedside? Oh wow, what an amazing question. That's actually going to be really a big part of what happened. But yes, there was somebody else with him. We don't know yet what their relationship is. But you will.
Okay. I would look for food poison as well. I would ask about the things he have ate before
Oh my gosh.
the event.
Philippe, please don't tell me what you would have done. I'll feel even more bad than I did already. But yes, I think you need a lot more information now. I've only given you this much. Really, really good question. Where are you calling from, Felipe?
I'm from Brazil,
From Brazil. Where in Brazil?
in São Paulo.
Sao Paulo, amazing. My dream is to
Yeah.
go there someday. Thank you for
Yeah, you
joining.
should definitely come.
I'd love to. Let me see what else people are saying in the chat. Bowel signs hyper or hypoactive. Okay, so questions about bowel sounds. There was an amazing episode of Core IM. Core IM is one of the best podcasts, only one of the 3 or 4 internal medicine podcasts. They did an episode about bowel signs where they reviewed the literature and taught me about a year ago that the value of bowel sounds in the acute abdominal patient is really, really not borne out by the literature. So I encourage you to check it out and come to your own conclusions. Just Google Core IM bowel sounds. Check it out. It changed my practice. I no longer listen for bowel sounds. Okay. Yeah. By the way, I'm gonna get so many people who are gonna jump on me for that comment, but I don't. I'm not perfect. Oh, thanks, Yusuf, for finding it. Appreciate it. Yusuf is putting it in the chat. Appreciate it, buddy. All right. Any other questions? Is the patient febrile? Did we say that? No, the patient is not febrile, afebrile. Okay. All right, y'all. So I hope you join next time. This will be a very, 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 very illuminating case. Okay. Oh, recent weight loss, Shema, I didn't ask it, actually. Yeah. Unknown at this time. Yeah. So let me be clear. I'm going to tell you this story, the whole version of it, next time. But we can't see this patient in the next 3 minutes because we're almost at the hour. So let me tell you what happened to our, I know, let me tell you what happened. Oh my gosh. Oh, you guys got to join live. People are losing sleep over this. Anyway, let me teach you all something really, really important. As a teacher, I've been teaching now for, oh my gosh, 7 years as an attending. You should never, ever finish your teaching. If you finish your teaching, you finish it, then the session's over. Teaching is never over. So every time we do this shift, we will always end with insomnia for most of you, especially those of you who really, really care. So get used to it. I won't tell you what happens, but I'll tell you next time. Let me tell you, though, about our patient who is, remember, he's really sick, y'all. Focus. He's really, really sick. So we go back, and some of the data is back. Okay? So this is for you, Aisha, for the scribing team. I'll just keep it simple. CBC is normal. Creatinine is normal. Electrolytes are all normal. In fact, I'll just tell you all the 1 or 2 things that are abnormal, but all the basic labs are normal. His BNP is 2400 BNP, the heart failure blood test. And that's the only thing relevant on his labs. His EKG shows severe sinus tachycardia, initially 120, no arrhythmias. Chest X-ray, bilateral interstitial infiltrates. Point of care ultrasound, I'll tell you the summary. B lines and an IVC that's about 2.5 centimeters. And he starts to get better and better and better. And thank you, Austin, non-collapsible, 2.5 and non-collapsible. And Utox, positive for cocaine. And I'll tell you one other thing, troponin is negative. Okay, last breakout rooms. What's the diagnosis? How are you going to manage it going forward? And we'll reconvene in 5 minutes, okay? Hi, Brianshu.
Hey,
How are you?
I'm good. How are you?
Well, where are you joining us from?
I am joining from Augusta.
Oh, amazing. One of my favorite places. That's awesome. Are you basking in the sun, I hope?
It's not that sunny right now, but yeah.
Oh, the odds were in my favor, but I lost this time. Nice to see you. All right, y'all. Sorry. I realize that I really have to work on the time management. I realize we're over. So hopefully we'll iron that out and work on that next time. Maybe I can ask Kirtan. Kirtan, what did your group settle on?
Yes, so fortunately, I worked with Priyanshu, Francisco, and Onine. All of them were so involved from the first aliquot itself. And actually, in the first aliquot, we did say that apart from chest section EKGs, we do need UTOX because this patient could have cocaine, amphetamine, or ecstasy thing causing the scape or FEOSPE. So we asked for it and we received it, right? So I think the first step should be giving the patient benzodiazepines because it will also calm down everything. And we also talked about the blood pressure management that now that we are beyond 180 margin and we started at like 210, we should slow down because we don't want to cause acute ischemic stroke as well.
Excellent.
That's the one thing. And we also wanted to make sure that we get the CTP just in case we didn't miss the aortic dissection because we know that cocaine can still cause aortic dissection. And our last summary was that although fluid overload was the predominant cause causing everything, we would just like to see the CT scan and the lungs as well, in case the inhalation of cocaine caused any pneumonitis or ARDS-like picture, which may not respond just to the blood pressure management, and eventually the patient would collapse again. So those were our thoughts.
Absolutely superb. Thank you so much, Kirtan. So, Kriti, what was your group's thought?
I think we were thinking on similar lines in terms of both the treatment and the diagnosis, as Kirtan mentioned. So the treatment would we would prioritize the treatment, but also thinking about the way it's hard to ignore cocaine being part of the final etiology. And I know we keep learning how that we should iterate the problem representation, but here thinking about how cocaine can affect the cardiovascular system, and like Kirtan mentioned, not anchoring on the volume overload or the features of volume overload, and also thinking about how it can affect the vasculature.
I think that's absolutely superb and a great segue into a visual that I wanted to share with you about what a good representation of what this is. And there are many words for it. The traditional word for it has been flash pulmonary edema, but Yusuf and the VMR crowd is sharing a great podcast episode from MCRIT. You should just Google MCRIT-scape, and it really elaborates on this concept. But what's the common denominator here? The common denominator is that the patient has a rapid increase in LV end diastolic pressure. That's what we're targeting. The patient's LV end diastolic pressure skyrockets. And that pressure is then transmitted into the pulmonary circulation, resulting in rapid pulmonary edema. And we really have to lower the LV EDP as quickly as it came on. But here, we're talking about the underlying causes. This is where this patient had a very wonderful surprise waiting for us to discover, which I will tell you in a moment. The most common reason why there's a rapid increase in the LV end diastolic pressure is there's a rapid increase in afterload. Either because the patient had renal artery stenosis and took an NSAID, or the patient has obstructive sleep apnea and has an obstructive apneic episode in the middle of the night, or the patient took a sympathomimetic, as is the case here, or the patient has really bad hypertension, forgot their meds, and flashed. So you really are saying there's something in the plumbing, and the pressure in the vasculature went really high up, transmitted into the LV EDP. You have to be very careful because you wonder, does everyone with a rapid increase in their blood pressure get flash pulmonary edema? The answer is no. So almost all patients with this mechanism, including cocaine, have an inherent vulnerability in their heart. Now, don't get me wrong, the stimulus and the increase in the LV EDP and the systemic afterload may be so high that even if you have a perfectly healthy heart, it'll flash. But what better way of bringing out your cardiac vulnerability than to have a dramatically increased blood pressure? There's no better way. And if you think about all these things cause cardiac issues inherently. Long-standing hypertension from the first two, and we already talked about cocaine and what it can do. So in most of these patients, there's something inherently wrong with the heart as well. And the most common thing is that there's left ventricular diastolic dysfunction. Flash pulmonary edema, a rapid increase in the LV-EDP transmitting into the pulmonary circulation. The most common cause is a rapid increase in the systemic blood pressure, but you have to be open to an intrinsic cardiac vulnerability. I was so happy to see this patient's chart after I admitted him to medicine to see that he was diuresed to euvolemia, needed no baseline diuretics at all because he flashed. He got excellent counseling on his cocaine use, and it was one of the very few patients whose life changed radically after this hospitalization. Because what I later learned was this had happened to him, this very thing had happened to him over and over and over again. After I had time to settle and actually look in his chart, he had had 5 similar incidences in the last 3 months. Goes home, totally fine, no diuretics whatsoever, uses cocaine, boom, back in the hospital, flash pulmonary edema, and the cycle continued. And he was able to finally get housing, which was the one big thing that put a halt so far to this cycle. But what did I learn? He had severe mitral regurgitation on his transthoracic echocardiogram at euvolemia. What was his vulnerability? Why was this happening to him over and over and over again? Don't get me wrong, cocaine didn't help. But what happened was he had developed severe myxomatous mitral regurgitation. And why is that a bad thing? If you're in the left ventricle and you have 2 options when the ventricle is squeezing, one option is to go out to the aorta, and now you have another option that you normally don't have, which is now you can go up the mitral valve into the left atrium, because normally that mitral valve is closed, but in people with mitral regurgitation, they have 2 options. What option are you going to choose if the aorta is at a blood pressure of 210 because of cocaine? You're going to go down up into the left atrium. So what's the biggest takeaway from this case is understanding flash pulmonary edema as a issue with LV-EDP, where most people have high systemic blood pressures as the cause, but almost all people have an intrinsic cardiac vulnerability. Most of those patients have diastolic dysfunction as their vulnerability, but a fraction of patients have other issues. And so thankfully now, after abstinence from cocaine for 6 months, he's being considered for mitral valve repair. And I'm sure that that is a large driver of the reason as to why he was so vulnerable to this blood pressure phenomenon. So to summarize, we talked about a patient who got really sick from a hypoxemic perspective. The ultimate diagnosis here is flash pulmonary edema due to the synergistic effects of intermittent cocaine use and continuous severe myxomatous mitral regurgitation. So before I pass the mic to Alex to take us through the teaching points, I just wanted to emphasize the exercise that we'll do next time. We'll continue the story of a 34-year-old man who woke up and had severe nausea and vomiting. And we learned that he was tachycardic and hypotensive, and that we had made a mistake right there in that room. Big one. It won't be recorded. So if you are interested in hearing that story, please consider joining us live. And that way you won't be sick of having to listen to nothing when everybody's here in the breakout rooms. But I would love to turn the mic to Alex to take us through the teaching points. And if you all are interested, as soon as Alex is done, we'll open the breakout rooms for another 5 or 10 minutes for you all to debrief, reflect. If you want to, please, we're already over time. But if you want to debrief, reflect, ask questions of each other, and I will try to join every breakout room for a minute or two to answer any questions that you all have. So mic to Alex for the teaching points, and then we'll do a final breakout room.
All right. Thanks so much, Rabih, and thanks so much, everybody else. Learned so much from Rabih and also from everybody else in the crowd. Just a couple of teaching points I'll share. So we started off the case with Rabih presenting us 3 different patients, one with hypoxemia, one with shortness of breath, and one with chest pain. And as a group, we talked about the ways to try to prioritize which of those patients we would see in a busy ER shift. So we talked about how with hypoxemia, that would probably be the patient that we would prioritize first on this list. Thinking about how patients with chest pain, the majority of patients presenting to the ER with chest pain have non-urgent etiologies of their chest pain, and then comparing and contrasting patients with hypoxemia versus patients with shortness of breath. Thinking about how patients with shortness of breath, the perspective there is that the patient thinks that there's a problem with the lungs, either bringing in oxygen or exchanging out carbon dioxide, versus for patients with true hypoxia, we have an objective measure that the patient has difficulty with that organ function. Later on, we talked a little bit about how we would work up and manage initially this patient who came to our ER with acute hypoxia and with an elevated blood pressure in the 200 systolic. We talked about that in breakout rooms, and then as a group, we talked about how some of the initial management we would do for this patient, and under the suspicion that this patient was in an acute hypertensive emergency, sympathetic crashing acute pulmonary edema, is that we would likely administer this patient nitroglycerin either via paste or via an infusion, in the hopes that we would decrease the left ventricular preload by giving that patient a venodilator, dropping the blood pressure and increasing that patient's cardiac output, decreasing the amount of pulmonary edema that was causing that patient's hypoxia. Some additional tests we talked about to try to confirm that diagnosis were a chest X-ray, an EKG, and a blood gas. And we also talked about some results of a point of care ultrasound that confirmed our suspicions. And then after that, Rabih talked us through some things that we could do acutely to try to manage this patient as soon as we went and saw them. We talked about assessing for evidence of pleural disease, but both with the focus and with the chest X-ray, and how if there were any evidence of an acute pneumothorax, we would have to drain out we'd have to suction out the air that was in the pleural space. We talked about administering the patient supplemental oxygen as needed. In this case, the patient was administered 6 liters per minute of nasal cannula right away. And we talked about the transition from the nasal cannula to non-invasive ventilation, in this case, to try to both to give the patient some positive and expiratory pressure to try to offload the left ventricle a little bit. And also we talked about supporting the patient's workup breathing with the contrast between the inspiratory positive airway pressure and the expiratory positive airway pressure, because presumably this patient who's had an extensive workup breathing for a long period of time may be developing a little bit of of CO2 retention, even if we don't see it just yet on the labs that haven't come back. After that, we talked about giving the patient loop diuretics. Rabih presented a great point about how a patient like this, he probably would start with at least 80 milligrams of IV Lasix, because the thought being that if you're giving the patient effectively, the loop diuretic would have something like a threshold effect, that if you're giving the patient 80 milligrams of IV Lasix, that's not going to cause double the urine output that 40 milligrams of Lasix would, especially if the 40 milligrams were to begin to work. But if we weren't getting much urine output with the 40 milligrams of Lasix, we want to start at least with something that would give the patient some some urine output. And I think Travis also presented a nice point in the chat about how the loop diuretics also have a bit of a bradykinin-like effect, causing a little bit of peripheral vasodilation, which would be helpful in a case like this too. We talked about how it was pivotal in this case to try to figure out why the patient was developing this really hyperacute increase in his blood pressure, and how important it was, like Kirtan shared, to make sure that we got a urine toxicology screen. And in this case, we found the patient to have cocaine toxicity. We talked a little bit both in the breakout groups and in the main room about how we would manage the cocaine toxicity, avoiding things. Some people mentioned in the chat avoiding some alpha antagonists because we don't want to we're avoiding beta antagonists rather to avoid unopposed alpha agonism, and giving some IV benzodiazepines to manage the cocaine toxicity. And then at the very end, Rabih compared and contrasted SCAPE, sympathetic crashing acute pulmonary edema, with acute decompensated heart failure, talking a little bit about how SCAPE was a little bit more hyperacute than would be acute decompensated heart failure. And also making sure in a patient like this that we look for reasons why the patient develops SCAPE, that not every patient who has a hyperacute rise in blood pressure is going to develop SCAPE, but a patient like this in particular had mitral regurgitation, which was what really predisposed him to having these recurrent events. So looking for things like mitral regurgitation, cardiomyopathy, and yeah, those are pretty much the teaching points I have. And then big cliffhanger, of course, about the patient for next time, the young gentleman with hyperacute abdominal pain, nausea, and vomiting. The only teaching point I have about that, based upon the discussion we have so far, is just the bit about the vowel sounds, how it's controversial whether or not vowel sounds are really supportive in developing your differential diagnosis. Sorry, I know I talked very quickly, but only because we had so much to get through in such little time.
I can't believe you're both doing that and paying attention to chat. That's absolutely amazing. I hope you saw the love you were getting in addition to the sheer velocity of your speech, which, by the way, I totally vibe with and I really love and appreciate. Thank you all for watching on YouTube. We'll end the recording here, and